Hey, good morning, everybody. Thanks so much for attending our webinar today. We have a really great one in store for you today. Today, we're going to be talking about MTHFR and understanding the connections to depression and how to treat those genetic variants with MTHFR and COMT. We have Dr. Valerie Ferdinand, who's our lead clinical consultant at Kashi Health. Dr. Charles Price will be joining us. He's a clinical psychiatrist. And Dr. Kim Hopke from MethylPro will also be joining us to discuss treatment. So without any more introductions, I'm going to introduce Dr. Valerie Ferdinand. She has an integrative practice here in Portland, Oregon. She's a doctor of naturopathy from NCNM, and she graduated in Portland as well. She's also our lead clinical consultant for Kashi Health, and she's here to support doctors in the use of genetic testing in their practice. Thanks so much, Dr. Ferdinand.
Thank you, Brian, so much for that kind introduction. Hello to you all, and thank you for joining us this afternoon. I'm very honored to be joined today with Dr. Charles Price, MD, and Dr. Hopke. We're going to be talking about MTHFR, COMT, and a few other variants that can have influence on depression treatment in your patients. So without further ado, we will get started. So today we're going to be discussing MTHFR and COMT, specifically on how they pertain to mental health disorders such as depression. We're going to be talking about the higher occurrence rate of MTHFR in symptomatic patients. We're going to be talking about the mechanism of action of how MTHFR is affecting the pathogenesis of depression, and also talking about how MTHFR and COMT interact to affect depression in your patients. We're going to give a very brief introduction to future webinar topic, pharmacogenetics, and cytochrome P450 testing, and Dr. Price is going to be discussing clinical cases that highlight how these SNPs can direct treatment, and Dr. Hopke will be discussing some highlighted products for metabolic maintenance that can be utilized in this treatment. And then, of course, when we're all done, we'll address your questions specific to your patient care. So before we get started, I just want to ask everybody out there, make sure that they can hear us. If you could just type in your question screen, yep, we can hear you, that'd be great. We just want to make sure everybody's getting this message loud and clear. I see a yes, thank you so much. We're gonna proceed. So if you've been with us before, you've seen this disclaimer, so I'm not going to read it verbatim. But basically, all of the treatment that we are making is intended to be carried out through the proper guidance of a physician or other healthcare provider. If you are attending this webinar and are not a healthcare provider, you assume responsibility for enacting any of these changes. With that, we will move on. So I'm here representing Kashi Labs. Kashi Clinical Labs was founded in 2006 to address the unmet need for accessible HLA testing in the transplant community. More recently, in 2012, our director has taken a more clinical approach to be able to offer scientifically rigorous genetic testing options to all of our providers. We are constantly looking through the literature to come up with the best SNPs and the best treatment recommendations for you, and we're currently proud to serve providers across the United States and internationally. We are accredited through CLIA, ASHI, and CAP, and as I said, every day we're working hard to bring you the best testing and reporting possible. MethylPro is a manufacturer of L-methylfolate supplements. As you'll learn through our presentation, almost half of all people have genetic variations that reduce their ability to convert folic acid to L-methylfolate, the activated and needed form of folate. MethylPro promotes healthy mood, cardio, and nerve function and supports the production of the neurotransmitters serotonin, melatonin, dopamine, epinephrine, and norepinephrine. And MethylPro makes a variable dosing options of L-methylfolate products available directly to consumers at a considerable savings compared to competitive brands. But today we're here to talk about depression. And many of you will understand what depression means in your patients, but just to briefly touch upon it, depression is defined as at least one major episode of depression in the absence of mania. At least 8% of the United States citizens aged 12 years of age or older have experienced depression in any 2-week period annually. To get even more complex, treatment-resistant depression is something that we'll be talking about a good amount today. These are your patients that are having an inability to achieve remission and improvement through at least 2 different trials of antidepressants. These patients are struggling, and providers are struggling to get them relief, and we're hoping to be able to shed some light on some missed key opportunities to be able to provide these patients relief. Depression in general contributes to significant medical costs annually. Upwards of $150 billion is spent on direct care, considering actual medications, counseling time, hospitalization, etc. But for those individuals, it doesn't end there. It also is affecting their day-to-day life and their lost productivity. People with severe depression typically earn $16,000 less annually, and while they may show up at work, they may not be fully engaged at work, therefore reducing overall productivity and that feeling of achievement in them. But probably the worst thing that depression leads to is an increased risk of suicide. Suicide is currently in the top two causes of death in adults aged 15 to 34. This is atrocious. This is something that we are hoping to be able to support you in improving through better treatment and through better diagnostics through use of genetic testing. So a very important report that many of you will be familiar with is the STAR-D report. The STAR-D report looked at a large subsection of representative adult outpatients with major depressive disorder that were put through a series of treatment steps to try to achieve remission. Through these steps, we saw paltry remission rates. In the very first treatment step, only roughly 1/3 of those individuals were able to achieve remission. As the patients are put through the successive steps, again, the results in the individuals that were able to achieve remission just continue to fall off and fall off and fall off. So we're seeing that patients who fail to remit after successive treatments have a low probability of ever achieving that remission. So what are we missing in the treatment of these patients? What can we be doing to support them better? So this is just a flowchart of the actual steps that the patients were put through in the STAR-D report. As you can see, the first step, the individuals were started off on citalopram. Step 2, in some cases, they were switched to a different medication. In some cases, another medication was added. In some situations, the medication was supported through cognitive therapy, and on and on and on and on it goes. However, once we get down to here, just remember, roughly only 10% of those individuals are achieving remission. So that's something that we need to improve to be able to improve their quality of life. Now, there's many factors that, of course, contribute to depression. Emotional disturbances are probably going to be your most significant factor, but there's other things that, as we're treating our patients with depression, we need to be considering that we can rule out and see if there's something that is a barrier to their improvement. Environmental exposures to heavy metals have been associated with depression. We'll get into it a little bit more later, but other environmental factors such as xenobiotics can also be a factor in depression. Hormone regulation, predominantly an issue here is going to be thyroid, but in some individuals, particularly those going through significant life stage changes, any alterations to the steroid hormones such as estrogen, progesterone may also be contributing to their depression. But all of it kind of calls back into the neurotransmitters and neuroinflammation. If we can get a better understanding of what's happening in this area, we're going to have a better understanding of how we can adjust treatment to be able to support our patients. And where all of these things come together is going to be your genetics. Namely, the 2 main genes that we're going to be talking about today, MTHFR and COMT. These 2 genes hit both ends of neurotransmitter metabolism and are very important as it pertains to neurotransmitter levels in the body. Other factors that we'll, like I said, just briefly touch upon is pharmacogenetics. Pharmacogenetics, as we will explore a little bit more, is the study of how your body is metabolizing medications. And as so many of these individuals are either going to be presenting on medications or may need to be initiated on medications, having an understanding of this aspect of the genetics also helps to improve treatment outcomes. So first and foremost, let's just get a good understanding of our neurotransmitters. We're all familiar with what they are, but how do they play together? So when we're looking at depression, patients with depression, we're looking predominantly at serotonin and dopamine, and to a lesser degree, norepinephrine and epinephrine. Serotonin is going to be more of your inhibitory or your calming neurotransmitter. So we want to make sure that those levels are properly supported so that our patients can have that inner sense of calm, that inner sense of happiness. But it must be balanced with dopamine, whereas dopamine kind of has a dual factor in neurotransmitter production. It can both exhibit an excitatory state and an inhibitory state. So when we see these two together, if we're not in a proper balance, then this is where our patients are going to be, in many cases, experiencing depression, and in some cases also experiencing more of that mania, but we won't be getting into that as much today. When our patients are exhibiting low serotonin type symptoms, they're going to be higher levels of impulse, aggression, things of that nature. Whereas when we have low dopamine levels, on the other side of that spectrum, we're going to have patients with more of a disinterest and a bit of a blunted affect. And those individuals that have high dopamine, as we'll discuss in the impact of the COMT polymorphisms, they're going to be reflective of those serotonin deficiency states because that balance has been affected. Elevated dopamine is going to result in a symptom picture very similar to low serotonin, and if we can correct that imbalance, we just help our patients to achieve that better balance in general. So here's just kind of a visual representation of what that dopamine deficit and that serotonin deficit may look like. So with the serotonin deficit, we have that impulsivity, we have that obsessiveness, we have that high level of excitability, and that's also representative of our high dopamine patients. Our low dopamine patients are going to have that slower reaction time, that less interest in positive reward-seeking behaviors because they're not getting that dopamine push that reinforces that reward. We're just going to have an all-around sense of disinterest and sadness. So what we want to do is we want to be able to help them both achieve a proper balance that both improves serotonin and dopamine levels so that they can achieve symptom regression. The other side of this coin is going to be neuroinflammation. Now, inflammation is, of course, linked to a multitude of health disorders, but more and more research is coming out to point to the fact that it can be very influential in depressive type symptoms. Depression and cognitive impairment are brought on by cytokine-induced imbalance. Not only are we going to see key enzymes in the kynurenine pathway upregulated in a inflammatory state, we're also going to see an impact on methylfolate levels. So to step that back a little bit, the kynurenine pathway is responsible for converting tryptophan into serotonin. So we're not getting as much tryptophan availability if we have an upregulation of a key enzyme in this pathway, the idolamine 2,3 dioxygenase, which we're just going to kindly call IDO at this time. When we see the IDO enzyme upregulate, that's going to redirect the tryptophan away from serotonin production, so we generate a situation that leads itself towards lower serotonin. So these individuals who have elevated inflammation that is increasing the activity of this particular enzyme not only are going to be having less available serotonin, but it also pushes them down a pathway to be able to generate more neurotoxic metabolites of this pathway, such as the quinolinic acid. So we need to be able to look at the whole symptom picture and to look at areas where inflammation may be elevated to be able to properly support this pathway. The other side of neuroinflammation is where we're going to have the methylfolate coming in. So methylfolate is very strongly associated with neuroinflammation, as the methylation pathway is directly responsible for neurotransmitter production, for control of neuroinflammation, and for proper balance of methylfolate and folic acid. So understanding your patient's ability to generate active folate as opposed to inactive folate will not only support energy levels and reduction of fatigue, but with reduction of this neuroinflammation that can be predisposing towards their depressive symptoms. All right, so we've talked about MTHFR and COMT a little bit, so let's get a better understanding of where they fit into neurotransmitter production. I like to think of MTHFR as kind of the front end. MTHFR is responsible for neurotransmitter generation. So what happens in this is MTHFR is responsible for helping to regenerate tetrahydrobiopterin, or BH4. And as we discussed in our previous slide, it also influences levels of neuroinflammation. But if we don't have the other side of this spectrum controlled through COMT, then we can have improper neurotransmitter levels, because COMT is responsible for neurotransmitter metabolism, and therefore the breakdown of neurotransmitters. So depending upon which polymorphisms your patients exhibit, they may be predisposed to higher levels or lower levels of neurotransmitters. And COMT is highly impacted by various different metabolites in the body that can affect its function as well as neurotransmitter levels. COMT, as we'll talk about in just a moment, is also strongly influenced by MTHFR, and together not only do they cover both ends of this spectrum, but they also are going to be controlling neurotransmitter metabolism. So to think about it in more of a visual sense, MTHFR is balancing out MTHFR and COMT is very important for proper neurotransmitter levels. MTHFR, in some cases, if it is not working, we're not going to have enough neurotransmitters being produced. And if COMT is not functioning properly, we may have too many neurotransmitters available. MTHFR, as we've discussed in previous webinars, is responsible for many, many functions in the body. But we're just going to touch very briefly on this, just to make sure everybody's on the same page. MTHFR is, as we said, responsible for converting folate into its active state. It converts the 5,10-methylene tetrahydrofolate to 5-methyl tetrahydrofolate, a very important step in the body. It contributes to S-adenosine methionine generation and BH4 generation, which are probably the two most important factors that we're going to be discussing today as they pertain to depressive type symptoms and symptom improvement in your patients. So MTHFR plus BH4 equals neurotransmitters. As we can see right here, and unfortunately it doesn't say MTHFR, but right here is where we're utilizing MTHFR to be able to regenerate BH4 tetrabiopterin from its inactive state BH2. Now, BH4 is exceptionally important in the generation of all of our neurotransmitters. It is a cofactor in each of the regulating enzymes responsible for converting amino acids into their active neurotransmitter state. So if our MTHFR isn't functioning properly and we don't have the proper cofactors to be able to support this BH4 regeneration, we have a negative impact on the potential to be able to generate neurotransmitters. But one thing I did want to point out is that this particular slide talks about folic acid and how it can be utilized to support BH4 generation. That's a bit of a side effect of the fact that many scientific studies are carried out utilizing folic acid as opposed to L-methylfolate. If you've been with us on our previous webinars, things that we've discussed is that excessive levels of folic acid can actually inhibit the ability of active methylfolate to properly cross the blood-brain barrier. So in our patients that are exhibiting depressive type symptoms and have MTHFR polymorphisms that reduce their enzyme's ability to generate active folate, we definitely want to be focusing their treatment on L-methylfolate, because if we focus it on folic acid, we are setting our patients up for a situation that could potentially induce that neuroinflammation that is contributing to their depressive type symptoms. So we need L-methylfolate and also SAM. In some cases, some patients may receive it in a supplemental form, SAMe, to properly regenerate BH4 from BH2. So MTHFR variants are strongly associated with unipolar and bipolar disorder. As we've discussed, 5-methyltetrafolate is necessary in the production of our monoamines, and we've seen in studies that individuals with low red blood cell folate levels are much more likely to be non-responders to antidepressant therapy and less likely to achieve and maintain remission. So through improvement of enzyme function, through improvement of neurotransmitter production, supplementing with active folate can greatly improve symptoms and decrease the treatment period to achieve better results in your patients. And in many situations, these patients are going to be co-treated with active methylfolate and antidepressant. And in those patients, in many ways, we'll actually see an improvement in response to their antidepressant therapy. Through utilization of the active folate, median times to major improvements dramatically decreases in patients, and patients achieve much greater functionality through the use of the augmented antidepressant therapy with the active folate. So one thing to always keep in the back of your mind when you're having a patient with treatment-resistant depression is, what is their methylfolate status? What is their MTHFR status? And is this something that I can be improving to be able to improve their symptom remission? So to just touch on how the polymorphisms are going to affect enzyme activity, this chart is something that we've seen in a few of our other webinars, but it's always very useful for our providers. This is a good representation of how the polymorphisms are going to affect enzyme activity. As we see, the 677 has the most dramatic effect on enzyme activity, where our homozygous patients have a 25% of expected enzyme activity, meaning roughly 1/4 of the anticipated active folate would be available to these patients. And as we go up, we see the heterozygotes, the compound heterozygotes of 1298 and 677 have roughly 50% enzyme activity. Heterozygotes for 677 have roughly 2/3 enzyme activity, and heterozygotes for 1298 have roughly a 20% reduction in enzyme activity. So across the board, we're seeing these patients have this drop in enzyme activity and can easily be supported through proper supplements through companies such as Metabolic Maintenance, as they will be talking about later. But one thing to be cognizant of is that these individuals that present with major depressive disorder, a much higher proportion of them are going to exhibit a polymorphism. In this particular study, roughly 70% had at least one polymorphism in the 677 enzyme. So they are having symptoms that can easily be improved through the use of active folate. We just need to be screening and identifying them. One thing that we've noticed through the testing that we've performed here at Kashi Health is that approximately 87% of the patients that our providers have identified as symptomatic and would require testing have tested positive for at least one polymorphism in either the 677 or the 1298 alleles. And this is a significant increase from the general population prevalence of roughly 25%. So if the moral of the story is, if your patient is showing symptoms, it's a very good idea to run testing to identify those SNPs, because it's a high probability that they're there and that we can improve their life if we identify and treat them. One thing that comes up quite frequently is the differentiation between 677 and 1298 and how it pertains to mental health. In many situations, 1298 has been reported to have a more influential effect on mental health disorders. Now, 677 in the literature gets all the glory because it has the greatest influence on enzyme activity and the greatest influence on homocysteine levels, whereas 1298 doesn't have as much of an effect on homocysteine levels. So why is it consistently associated with this increase on mental health disorders? A study that I recently reviewed of 613 major depressive patients, 389 of which had treatment-resistant depression, the homozygote of 1298 came up much more frequently in the patients that exhibited the major depressive disorder. So why? What is likely occurring here is that the 1298 allele occurs at a site in the gene where S-adenosyl methionine binds to the gene. Why is that important? Because the SAM binding occurs during the BH2 to BH4 regeneration. So in these individuals that have the 1298 homozygote, in a key situation where that SAM binding occurs, they may be having inefficient BH4 regeneration and therefore inefficient neurotransmitter production. Now, just as a caveat, this hasn't been fully studied because 1298 doesn't have a whole lot of support behind it, but literature and just understanding of how the gene is structured is leaning in that direction. So use of SAM in your 1298 patients that have mental health disorders is likely going to be indicated. So this just kind of brings us back to the picture that we had looked at earlier. Just a review of how the methylfolate in the SAM is involved with the BH2 to BH4 regeneration, and how MTHFR is the key enzyme that is SAM dependent in carrying out that reaction. Now just remember, MTHFR also generates SAM. So we're kind of hit on a double whammy here. We need active methylfolate to be able to properly generate SAM, and we also need SAM to be able to regenerate BH4 from BH2. So we need to make sure that these patients have adequate amounts of active methylfolate to be able to carry out two very important steps in this process. All right, so MTHFR has gotten a lot of love so far, so we're going to just touch upon COMT. The COMT gene codes for catechol O-methyltransferase, an essential enzyme involved in the inactivation of our catecholamines, dopamine and norepinephrine, and the catechol estrogens. So that's one thing to keep in mind. COMT not only has an influence on depression, but it also has an influence on estrogen states. So in some cases, female patients with COMT polymorphisms are actually in a worse state than male patients are. Its enzyme is active in the prefrontal cortex, the area of the brain that gives rise to our personality, emotions, behavior, etc. And key polymorphisms at the Val158 MET allele are highly correlated with how our body is handling this catecholamine metabolism. The two polymorphisms that are possible at this location is going to be the Val or valine amino acid or the met-methionine amino acid. The two possible alleles are codominant, and they each exert equal influence on the outcome of the enzyme. So therefore, if we have the Val allele available, then it is going to have the same impact on the activity of the enzyme as the MET allele, but in two very different ways. Having two of the valine alleles is associated with a higher ability to degrade the neurotransmitters, whereas two of the methionine alleles is associated with a 3 to 4-fold reduced ability to degrade neurotransmitters. Now, for our patients that have one of each, because of this codominance, in some ways they are theoretically predisposed to be associated with balanced neurotransmitters, but that's not always the case. So COMT, the main catecholamine that we're looking at in depressive patients is dopamine. So COMT is dependent on MTHFR and interacts with MTHFR in two capacities depending upon which allele is present. So because MTHFR is involved in the key enzymes such as for dopamine, the tyrosine hydroxylase in neurotransmitter generation, but it also is required for SAM generation that is also needed in that enzyme. SAM is also a substrate for proper binding in the COMT active site for metabolism of the catecholamines, so we need MTHFR to be able to support not only neurotransmitter generation, but also proper neurotransmitter metabolism. So depending upon which polymorphism your patient has, they are still going to need to have an understanding of what their MTHFR is, but depending upon if they're a val or a met, it may be important for generating more neurotransmitters or for clearing out an excessive amount of neurotransmitters. All right, so I'm just going to go through this relatively quickly. Pharmacogenomics is a very large topic that we'll be covering in future webinars, but I know Dr. Price is going to be discussing it a little bit in his case study, so I don't want it to be completely foreign to you. So pharmacogenetics is a study of how your genetic makeup affects your ability to metabolize drugs. It's based on the single nucleotide polymorphisms, very similarly to MTHFR and COMT. And depending upon the variation, your patient may have an effect on how drugs are metabolized. So the genes that we're looking at in pharmacogenomics is predominantly the genes involved in the phase 1 cytochrome P450 system. The ones that most genetic tests are looking at are going to be the genes for 2D6, 2C9, 2C19, and the interaction of 3A4 and 3A5. Other proteins other genes that we'll be looking at in other situations, not necessarily with mental health disorders, would be proteins that transport drugs, but we won't be discussing that today. Generally, in mental health, we look at the CYP2D6 and the 2C19 genes, as these are the ones that are most influential on the metabolism of medications associated with mental health. Other things that we look at, of course, in mental health is MTHFR and COMT, as we've already discussed how they're so important through proper regulation of these patients. So there's many cytochrome P450 enzymes, but the ones that I said we're most interested in is the 3A4, 3A5, 2D6, 2C19, and 2C9. Through testing, we can get an understanding of how these genes are functioning, but they don't function in isolation. These, of course, are influenced by gender, by level of inflammation, by age, things like that. So again, taking into consideration your patient's entire history picture, understanding the metabolism of the drug metabolism ability of your patient in the context of gender, inflammation, etc., can be very useful in selecting proper medications. How the pharmacogenetics is reported is by phenotype. Your patient may be identified as an extensive metabolizer, which is essentially a normal metabolizer, an intermediate metabolizer, which has a slightly reduced ability to metabolize medications, a poor metabolizer, which has a significantly reduced ability to metabolize enzymes, or an ultra-rapid metabolizer that will actually clear out those medications at a higher rate or convert them to an active drug at a higher rate. So just kind of looking at that visually, the ultra-rapid metabolizer has more than one active allele, and therefore they're conducting at a much higher rate. The extensive metabolizer either has 2 of the normal alleles or 1 dysfunctional allele, but that doesn't have an impact on the actual phenotype status. The intermediate metabolizer may have 2 partially defective alleles in the fact that they're not able to exhibit full enzyme activity, or a partially defective allele with a null allele. So a null allele has no activity and significantly reduces enzyme activity. And that's what we see in our poor metabolizers. Those patients are going to have virtually significantly impaired ability to metabolize that medication, and we may get poor treatment response through that situation. What we do with the information from the phenotype status is we then go to databases such as PharmGKB that give dosing guidelines on how to utilize medications based upon your patient's phenotype status. It's very well researched, very well supported, and has a broad database of different medications and how their dosing can be interpreted in light of pharmacogenetic data. So with that, I'd like to turn things over to Dr. Charles Price. He's a dear friend of us over here at Kashi Health. He is a highly regarded and highly sought after speaker worldwide. He's a clinical psychiatrist and clinical professor of psychiatry at the University of Nevada, Reno, and has a private practice in Reno, Nevada in adult psychiatry. He was a key player on the APA task force on the development of the DSM-5 and is a wonderful resource for us to learn a little bit more today. With that, I give you Charles Price.
Thank you, Valerie. Boy, that was a tour de force. I learned a lot myself in listening to you there. What I want to do now is bring all the wonderful information on the biology of this down to, and the biochemistry, down to looking at actual cases. Because as well as being clinical faculty, I also have my own private practice and actually have to deal with patients. They, where the rubber meets the road is does things help patients. So I wanted to give you a case here where I had a patient in my practice for quite some number of years before genetic testing was really in the fore. And when genetic testing came around in Kashi Labs, I was able to look a little more deeply into the patient's situation and see if I might be able to do something differently. Anyway, this is a 45-year-old now male with major depression, concomitant OCD, and ADHD. So as most of our patients, they're not clean research patients where you can have one diagnosis. He had substance abuse and seizures in the past, and indeed still has some seizures. Family history: his mother had depression, suicide attempts, abusive meds. Sister with depression, fluoxetine did not work for her, escitalopram did. Maternal aunts had history of addiction. So we're thinking here a couple things. Maybe there's a genetic component, epigenetic component perhaps. Maybe there's a psychodynamic component involved, but we're going to talk about the genetic components at this point. So when we look at family history, is so important because that's a quick way of looking, quick and dirty way of looking at, is there a reason to think about genetic testing? So let's see what we found out with this patient on the next slide. So the meds he's on. This is over many years. He had tried many different medications, including sertraline, didn't have any response, methylphenidate, some abuse issues with the combined salts, but abuse issues was always an issue there. And fluoxetine worked for a while and then petered off. Venlafaxine and bupropion worked for 2 years and 6 months respectively. So Some benefit, some little boost, but kind of coming back to baseline. No response from escitalopram, and partial response to some other medications you see on the slide there. So obviously, as a patient that for many years we've been working on many different things with, and we can look at the next slide and see that it made sense to order pharmacogenetic testing because we really wanted to look and see what's going on here. Well, look, as I say, look under the hood and see what's happening. So he was a poor metabolizer of 2D6. That may lead to some of the issues with venlafaxine, which, by the way, as you know, the more active form is the metabolized form. So that could be an issue with the venlafaxine. Amphetamine, dextroamphetamine, it's a mixed picture, but the poor metabolizer on that medication may also be problematic. And then the 2C19 is ultra-rapid metabolizer. And so with venlafaxine, we think of, okay, the desvenlafaxine may be more effective. So you'd want someone to metabolize it well. But on other psychiatric medications, maybe a poor metabolizer would be okay because maybe the prodrug, as you might call it, or the original drug, might be the more effective molecule. So a poor metabolizer in some ways may be good, and although if you give the normal dose, you may have side effects from a higher blood level of the medication. But in some ways, it may not be so good. So you really look at all these things. It's not a cookie cutter approach. You have to think about the medication and what's happening. So with the 2C19 ultra-rapid metabolizer, since in this case the parent compound is in some ways the active compound, maybe that's why because it got cleared from the system more quickly, it didn't work as well. Now, had I had many years ago genetic testing, perhaps I wouldn't have taken so much time to come up with treatment strategies that may tend to work better. And by the way, genetic testing is one part of the puzzle. It's not the be-all, end-all. It's another tool that we have. So you can't just take genetic testing and say, okay, this is what's going to happen with my patient. It's a guide to help us move along with less trial and error. So MTHFR, he was a CT allele of the 677, which means he had reduced activity, and he had the reduced activity of the 1298. So he wasn't creating L-methylfolate or MTHF as efficiently because of his MTHFR status. Okay, so then we can think of different strategies. Obviously, we're going to be looking at your metabolism aspects and trying to pick drugs that would suit his metabolism. But also, if you're not creating the neurotransmitters to start with, it doesn't really matter what's happening with the medication we're giving in most part, because most of our medications, remember, are trying to stop the destruction of neurotransmitters. But if you don't have any neurotransmitter to start with, it doesn't really help. So perhaps with low neurotransmitter levels, by having these MTHFR polymorphisms, perhaps that's one of the reasons that some of these medications that stop the destruction were working for a while and then stopped working so well because the supply wasn't there, keeping up with the need to move down the neuron line and affect downstream processes. So that's our thinking on this. Looking at the next slide, you can see here that so we started L-methylfolate, and for all the reasons that Valerie so elegantly talked about. And Valerie, I don't know if it's your experience or not, or in your reading or not, but in my reading, there may be some instances where if you have high levels of L-methylfolate, again, this is the active form. We're not talking about folic acid here. Folic acid, unmetabolized or unmethylated folic acid can actually sometimes be, as Valerie mentioned, have issues with inflammation. Maybe there's some literature out there, maybe even cancerogenic. So we don't want to just be slugging people with folic acid if they have this blockage. So anyway, so L-methylfolate, though, may in some cases be able to substitute for BH4 in that pathway of the creation of neurotransmitters. So sometimes, as well as helping convert the BH2, biopterin 2 to biopterin 4, it may also, if there's some genetic issues in that pathway, it may be able to actually substitute. So there's possibly several ways that L-methylfolate may be our good friend. So because of what we saw with the genetic testing, we're increasing doses of valproic acid because of metabolism and the really looking at our CYP2D6 status to make those evaluations. And so also we're going to reevaluate the amphetamine and dextroamphetamine dose. Now, one of the things that's so interesting to me, and I'm a big methylfolate fan because I personally have the CT form of MTHFR, and which is, as Valerie mentioned, is a slightly reduced form. But my son has the TT form, so he's, I call it double trouble, for the T's, and the CC form being cool. So he had a greater vulnerability, and as I've learned more, I'm realizing that the probability is that having the less efficient form of MTHFR may lead to micro insults throughout life that eventually culminate in things that we see, like depression, for example, we're talking about today. Of course, if you have the less active form of MTHFR, you may have also fertility issues, which we're not getting into today. But the point is that looking at these things early in life might not be a bad idea. In fact, my son now has a daughter. It turns out that she's never had a blood test done, but I know that she's a TT on the MTHFR 677. The reason I know that is because her mother, during pregnancy, the neonatologist did the genetic testing for the MTHFR, and the mother was a TT. So my son's a TT, mother's a TT, the daughter's a TT. The daughter's not even 2 years old. She's taking L-methylfolate. Why? Because we want the pathway to work efficiently, and just giving her more supplemental folate from all these different avenues, enriched flour and all that kind of stuff, is not what she needs. That will just increase potentially the type of folate that we do not particularly think is helpful, and not really help much with the L-methylfolate, which is what Valerie has talked about, so active. So that's really my message on this case. But what I want to really stress here is that this genetic testing, though it's still in its infancy, we're going to get better as time goes on, but it is a tool we have to use now to help with depression. Valerie talked elegantly about how so many people that come into our practices have a deficit in the conversion of folic acid into L-methylfolate, the active form. And now in my practice, unlike when I first was involved in genetic testing, almost everybody, I offer genetic testing to look at these things, because starting with the foundation of optimizing the production of the neurotransmitters, allows us then to manipulate with medication we've had out there for some time and we know a lot about, to help manipulate the destruction of them. Now, looking at COMT, and Valerie is way ahead of me on this, but my simplistic thinking of COMT in my world is, as we know, it destroys especially norepinephrine and dopamine. And so if somebody has the COMT Val or Val-Met, they're kind of destroying things at a pretty good clip. Of course, the Val a little bit more. But if you have someone with depression, you might want them to not destroy it at that normal clip or even accelerated clip. You might want them not really destroy it much at all. That's where your Met people have an advantage that way. Now, Met is not the normal form, but it doesn't destroy dopamine norepinephrine as quickly. And you'll notice in people that have gone to higher education, PhD, MD, naturopath, MD, ND studies, that they tend to have a higher predominance of Met people than does the general public. And that's probably because they have more dopamine available, prefrontal cortex, working on that part of the brain, so they're able to assimilate things a little bit better. So academically. So I think this COMT is important to look at here. Now, but again, if you have depression, you'd rather have less activity with the COMT. If you have anxiety can be dopamine norepinephrine related sometimes. You may want to have more destruction. So it depends on your patient and what's going on. Now with the COMT, there's some data out there that shows that, of course, SAMe can help decrease the activity of COMT, and also L-methylfolate may help decrease the production of COMT through the promoter, as well as the activity of the COMT itself. So L-methylfolate may work on both aspects, or three aspects really, of the constellation here: the production of neurotransmitters by being a coenzyme for the BH4, substituting for BH4 in cases, not as efficiently, but in cases, and also quieting down COMT so you have less destruction and more production. So that's kind of the basic concept I wanted to get across today. And maybe in question and answers we can go over some other stuff.
Thank you so much, Dr. Price, for all of your expertise on that. And just personally, thank you for the kind words. I would love to build upon that to just talk a little bit about some of our testing. For those of you who've been with us before, this is our test kit. It's universal and is able to test for the MTHFR, COMT, and the pharmacogenetics. Very simple collection instructions to be collected in office or at home at your patient's convenience. And then, of course, we're going to offer you our sample report. Our sample report is going to be able to easily identify your patient's mutations and their expected enzyme activity. And one thing that I just wanted to touch base on that Dr. Price had mentioned is that, yes, we definitely here at Kashi advocate for testing, not just because it's a good idea to understand your patient's polymorphisms, but in those cases where a patient with particularly high-risk health history, such as some types of cancers, we want to be very judicious in how we're utilizing those 5-methylfolate products. So if you have a patient that has no polymorphisms or has the 1298 AC, so as they're not having as reduced of an enzyme activity, by starting them out on an exceptionally high dose methylfolate, we may be putting them in harm's way. So understanding where your patient lies can help to give you a better understanding of where to begin and where to continue treatment. So we recommend for our patients that do have polymorphisms a fully rounded supplementation pattern. So choosing the correct form and the correct dosage of active folate is very important, and supporting with the other B vitamin cofactors to support all stages of the 1-carbon metabolism pathway is also very important to ensure that we don't get our process snagged up anywhere in the pathway. Utilization of betaine or NAC can also be very important, particularly for those individuals that may have elevated homocysteine levels, for those that may have some cognitive dysfunction, and for those who have more environmental exposures and have a reduced detoxification ability. These are all things that, of course, through your complete history and support through other testing, you're going to be able to properly identify and treat accordingly. All of our sample reports spell this out, and we are, of course, here to be able to help you with assistance in selecting dosing for your patients on where to start and how to proceed when you hit a treatment snag. For our COMT reports, we've designed them to also be as user-friendly as possible. So in this report, we have an individual that has the MET allele. As Dr. Price said, these are the individuals that have the higher dopamine levels. In some cases, this may be an issue with your depressed patients, but in general, these patients are more excitable. They're more OCD. Because they have that lower activity of that COMT enzyme, and so they have more naturally occurring neurotransmitters. To support those particular patients that are having those types of symptoms, again, we want to be looking at an active B complex so that we can get proper SAM generation and proper support through all stages of the COMT metabolism, but also magnesium. Not only is magnesium very calming, but it's also a necessary cofactor for binding in the COMT active site. Now, the patients that are more commonly experienced in a depressive type situation are going to be your VAL patients. So these individuals have the higher activity of the COMT, so they're cleaning out enzymes at a rate faster than their body can make them. So we need to support these individuals in better neurotransmitter production so that they can get a better sense of balance. Again, B complex, can't get away from it. It's really just important for supporting proper cofactors in many different SNP situations. But then to take it to the next level, we can also be supporting with things like vitamin C and vitamin D. Vitamin C and vitamin D support tyrosine hydroxylase function and also help to upregulate tyrosine hydroxylase function. But on the flip side, they are a mild COMT inhibitor. So therefore, we get slightly less activity in the COMT enzyme, so we're not clearing out neurotransmitters at such a rapid rate. But we also need to support through proper nutrition and proper precursors by giving phenylalanine, L-tyrosine, and L-dopa supplements as necessary precursors for neurotransmitter production. Green tea is also wonderful in individuals with VAL polymorphisms. It's neuroprotective. It can be helped to improve neurotransmitter levels, and also has a mild suppressive effect on COMT function. Now, we talked a little bit about the fact that the VAL-MET alleles are codominant, and so those individuals that have one of each theoretically should have balanced neurotransmitters, but you tested them for a reason, so they're showing symptoms. So what are we going to do with these people? We want to be looking for something that may be pushing the pathway in one way or the other. So for our patients that may have that more depressive type situation, we're looking at a situation where they're having reduced focus, reduced excitement, reduced interest, that blunted affect. What we need to be doing with these individuals is adjusting their methylfolate dosing to make sure that they have enough of those needed cofactors at the front end of neurotransmitter production, and then also supporting with the aforementioned aminos and overall good nutrition. But if your patient is following your treatment protocols and all of a sudden they start to exhibit more of an anxiety type picture, now we need to readdress their 5-methyl tetrahydrocannabinol folate dosing, maybe bring that down a little bit and look if the COMT inhibitors that we've utilized in these patients may be a little too high. Other things, just through environmental exposure and reducing things that can have an effect on the COMT enzyme, is doing a history on xenobiotics and looking for environmental factors that may be reducing COMT function. And then the last thing, as we touched so briefly upon the pharmacogenetics, Kashi Health does offer pharmacogenetic testing. We offer all of the cytochrome P450 enzymes that we discussed, and have a mental health panel that looks at 2D6, 2C19, MTHFR, and COMT. So if this is something that you're having treatment resistance in your patients through antidepressants and feeling that this may be something that may be very useful to get a better understanding of their medication metabolism, we're happy to support you in that as well. Now, to take it to the home stretch, thank you all for hanging out just a little bit longer. I'm happy to hand this over to Dr. Hopke. Dr. Hopke is a naturopathic physician with a private practice in Sisters, Oregon, and she's a consultant with Metabolic Maintenance and MethylPro, and from here on out, we'll be discussing some highlighted products from the MethylPro supplement line. And with that, I give you Dr. Hopke.
Hi, Dr. Ferdinand. Thank you for that introduction, and I really enjoyed the webinar so far. I've learned a lot. So I'm here with Metabolic Maintenance and MethylPro. Metabolic Maintenance has been formulating high-quality nutritional supplements. They're sold to healthcare practitioners, and we've been doing that for 30 years. More recently, MethylPro products were made to be sold directly to the patients of psychiatrists. Psychiatrists specifically asked us to come up with a less expensive form of methylfolate than was available at the time, and one that was easily accessible to their patients. Next slide, please. So MethylPro offers several products containing professional strength L5-methylfolate, and there's no prescription required for these. They are called dietary supplements, so they're available to the public. We have variable dosing options, and I'll go over those in a bit. They're manufactured using the highest quality ingredients. Our methylfolate comes in two forms, quadrafolic and extrafolate S, and I'll go into the differences in a minute. Both of these are formulated by the Italian biotechnology company Gnosis. They're self-affirmed as GRAS, which is generally recognized as safe, and they've been filed as new dietary ingredients with the FDA. They're manufactured in compliance with certified manufacturing processes. They're free of preservatives, fillers, binders, and artificial ingredients or excipients. Now, we do need to fill the capsules, and recently, until now, we've been filling the capsules with rice maltodextrin. So we try to look for the most beneficial nutritional support, and we were limited because of patent limitations on what we could fill it with. Those patent limitations have been lifted recently, so by next month, the MTHF is going to be formulated with glycine in the capsules, and glycine supports healthy neurological function rather than just being neutral. Our products are free of soy, dairy, gluten, and other harmful allergens, and they're vegetarian capsules in amber glass bottles. Next slide. So here you can compare our MethylPro products to Deplin products, and Deplin is a form of methylfolate made by Merck. It's classified as a medical food, so it's only available by prescription. As you can see, there's two dosing options for Deplin. It's also quite a bit more expensive than our MethylPro options. We've tried to have a lot of different dosing options, so from 2.5 up to 15, and we have two in between there, 5 and 10. And then we've also come up with some products that have cofactors and B complex that use the L-MTHF in it. And we haven't really talked about this, but because this is available to your patients, you want to make sure you educate them that they want the L form of methylfolate. They don't want the D form, and they don't want a mixed D-L form. And sometimes a cheaper form might just say 5-MTHF on it, and it won't designate that it's the L form, and all our forms are just pure L form. The D form is not helpful, it's not equivalent, and it's not going to help you absorb that the MTHF. Next slide. So this is our new facility. We've just moved across town, and this is where we are in beautiful Sisters, Oregon, and our new facility. So we just like to throw a picture in of that because we're all really excited about it. Next slide. Our standalone products, we have Extra Folate S. It's stabilized in a calcium salt-based molecule, and we offer it in 2.5, 5, 10, and 15 milligrams. We also have a standalone quadrifolic. That's a glucosamine salt-based molecule. It's slightly more bioavailable than the calcium salt molecule. The Extra Folate S is our most popular one. Next slide. So this is our B-complex plus, combining our best-selling B-complex with either 5, 10, or 15 milligrams of L-methylfolate. So this contains cofactors in methylation, B6 and B12, as well as a full spectrum of B vitamins, which aid in both producing and metabolizing neurotransmitters, as we've been hearing. As mentioned, the B complex is going to be beneficial whether the COMT enzyme is over or under functioning. Next slide. And this is our L-methylfolate plus cofactors. So you can get the cofactors with either 10 or 15 milligrams of L-methylfolate. It helps maximize the conversion of homocysteine to methionine and cysteine, promotes healthy homocysteine levels, and contains the mineral magnesium, which is a necessary cofactor for the metabolism of methylfolate. And as was mentioned earlier, magnesium is important when the COMT enzyme is under functioning. And it can help in the metabolism of dopamine, epinephrine, and norepinephrine. B12 is needed for the conversion of homocysteine to methionine. Methionine is a precursor of SAMe, which increases levels of serotonin in the brain. B6 is also going to aid in the formation of serotonin and norepinephrine. Next slide. I think it's worth mentioning that all our metabolic maintenance supplements, from our basic multivitamins to the MethylPro products, now use L5-MTHF rather than folic acids. So some of the detriments we've been hearing about folic acid creating in people with these polymorphisms aren't going to be an issue if you order even our basic multivitamins. So you and your patients can visit us at methylpro.com or call us at 888-242-5327 to order. And I'd like to thank Kashi Lab for setting up the seminar and having us take part, and to my co-presenters, Dr. Ferdinand and Dr. Price, thank you.
Well, thank you so much, Dr. Hockey. We think MethylPro products are some of the best to support patients with MTHFR polymorphisms, and we're happy to be able to have you with us to inform our listeners about its quality. So to wrap it up, just want to touch base again, the importance of MTHFR and COMT polymorphisms and how influential they are on achieving neurotransmitter balance in your patients. Testing, identifying, and treating accordingly is, for many patients, that missing step that's keeping them from achieving symptom remission. In those patients that are utilizing medications, pharmacogenetics can be a very, very useful tool to be able to understand how your patients are metabolizing their medications and how that may be affecting their response to their medications. And testing is very, very simple, inexpensive, and it's a once-in-a-lifetime test. So use it in your patients and move forward. So I want to thank you all for being here with us today, and then I'm going to turn it over to Brian, and we're going to address some questions that we have in the audience. Thank you so much.
Thanks so much, Valerie. Yeah, that was a really great presentation by the presenters. Thank you so much. I'm going to go ahead and open it up to the audience. Feel free to type in your question box if you have anything you wanted to ask us. Feel free. The presenters are all still here, so that's Dr. Valerie Ferdinand, Dr. Charles Price, and Dr. Kim Hopke, and would be happy to assist with any questions that you might be seeing with your patients or just want to know more about. One of the questions that came in during the presentation was that they wanted to know how safe it is for folate dosing with cancer patients.
So when it comes to dosing for patients with active cancer, I have a tendency to be very conservative. We need to strike that balance where your patients are still being able to achieve proper folate levels, because it is a commonly seen thing that cancer patients have depressed folate levels. However, we don't want to set up a situation with rampant DNA synthesis. Depending upon their polymorphisms, I would still start exceptionally low in the dosing. And then for those who have the lesser impactful polymorphisms, maybe even considering the folates from dietary sources as opposed to the active form. But still no folic. We don't like folic. So.
Thanks, Dr. Ferdinand. Next question is, hi, thanks for your presentation. Thank you. How much is the testing, and is it available in the UK? Testing is currently for MTHFR. It is currently $95. COMT alone is $60, and if you order them together, it's a reduced price because it means we have to do only one extraction, and that is $130. Is it available in the UK? It is. We actually have a distributor in the UK that we can refer you to. So the gentleman that asked this question, I will definitely follow up with you and get you that information. Next question was, so methylpro sounds like a great idea for patients, but if the patient has anxiety, test for COMT first before giving L-methyl or L5-MTHF?
Thank you so much. If you are having a patient with anxiety, I would still test them both, because COMT, if they have the MET, may have that higher level of excitability, may have more anxiety. But if you're treating with 5-methylfolate and giving a excessive amount, it can exacerbate their anxiety. So testing for both and understanding both will give you a better understanding of their individual picture. As for treatment, starting conservatively with methylfolate and titrating up will help to achieve that balance, and then we can integrate the COMT treatments once we kind of get them a little bit more stabilized with the 5-methylfolate.
Sounds great. Thanks, Dr. Ferdinand. Next question is the test saliva or blood? It's actually technically neither one of those. It's actually buccal swab, so we're just getting the cheek cells off there. It's very easy to administer. I would just say from our experience in testing, just make sure that your patients are swabbing accurately and that they follow those instructions completely. As long as they're doing that, there should be no need for a resample. We really don't have the need to resample very often, but it's fairly simple. They're stable for a long period of time, and two, we do recommend you get them back to the lab though as soon as possible. So buccal swabs are how we do the genetic testing. Next question, is there a product that to induce COMT? That may be a good one for Dr. Ferdinand or Dr. Hopke.
So a product to induce COMT. I have just scoured and scoured and scoured and scoured, and there is so much more evidence to items that inhibit COMT. I have not been able to find a proper COMT inducer. Do we have Dr. Price?
Dr. Price, yeah, let me go ahead.
So what we are recommending at this time is a support with the necessary cofactors to achieve proper COMT function. Dr. Price, if you're available, are you aware, or Dr. Hopke, of course, are you aware of any products that induce COMT?
No, I'm not. I think sometimes stress can induce it, but
yep.
Yeah, I was going to say basically the products we have are the cofactor products with the magnesium in them, and then also we have a product called In Gear through metabolic maintenance, which is B6 and magnesium, but those are, it's just the cofactor support.
Well, one thing I'd like to mention, you mentioned magnesium, that what we're talking about here, correct me if I'm wrong, you naturopaths, but we're not talking about magnesium oxide, which is what you get a lot of times over the counter. These are different forms of magnesium that are more active, citrate and slicing and so forth. Is that correct?
If you're asking about our products, is a magnesium citrate? Yeah.
Yeah. Yeah. Go ahead.
Yeah, and I think Dr. Price, you bring up a very good point about product quality, and that a lot of times our patients are resorting to over-the-counter treatments, and through professionals and professional product lines like metabolic maintenance, we can get proper substrates into their hands.
Not only proper substrates, but too much data out there now about how you buy stuff over the counter and it's not even what it says it is, or it's got adulterants in it, or whatever. And so it's, you know, I mean, buyer beware if you buy it over the counter.
Definitely.
Sounds great. Thanks so much for having that discussion. Next question that came in is, what about the CBS polymorphism? I also have a lab report for a patient that is very suicidal. I'm sorry to hear that. Could I fax it to someone for an opinion? He is a dentist, and I think heavy metals are involved.
So yes, the CBS polymorphism is also very important. It's kind of the next step in the chain of the MTHFR 1-carbon pathway. I'm very sorry to hear about your patient. That's horrible. I'm happy to take a peek at it. You're more than welcome to fax it here to Kashi Health, and we will provide you with our fax number as soon as we're done.
Yeah, and just for your reference, it is 503-206-6939. Again, 503-206-6939. Next question that came in. I came in today's webinar, but they were a little bit late, so they wanted to know if they could receive a copy of the slides. We'd be more than happy to send all of you a copy of the slides from today's presentation. We've also been recording what our presenters have been saying as they've been moving through the slides, so a video of that will also be available for your reference, and we'll get that out to you shortly.
So there's another question about over-methylation and under-methylation by testing for whole blood histamine. I'm familiar with the concept, but not strong enough to the point where I'm comfortable discussing it. The only thing that I do know is that histamine on some levels is not always a 100% reliable marker for over and under methylation, but it is something that a lot of people do use.
Great.
I open it up to the other presenters if they have any other information.
You're ahead of me on this one.
Okay, sounds great. I think that's all the questions that we had for all the presenters and from the attendees that were able to join us. Thank you guys so much. If you have any final thoughts to share, you're more than welcome to. Otherwise, thank you for a very, very good, informative presentation. I appreciate it.
Thank you.
All right. Goodbye, everybody.
All right, sit down.